And that's what we are. We're a peak advocacy group in New South Wales for people with intellectual disability and their families. And we've evolved from an organisation that historically was a peak of service providers through to one that was very much led by fantastic parent advocates to one now where our leaders are people like Michael. The majority of our board have to be people with intellectual disability, who then work with us and with family members and professionals to provide well-grounded systemic advocacy. I think a good starting point for just thinking towards the evolution of the 8 elements is to go right back to about 1980. Up until then, mental health services had included intellectual disability services. The main residential options for people leaving their family home was to go into psychiatric hospitals and to become involuntary patients under the Mental Health Act. But in around 1980, it became well recognised that intellectual disability was not a mental illness, and a separation of services occurred, which ultimately led to intellectual disability services moving out of the Department of Health and into community services orientated departments. And that, I think there would be a similar picture around Australia to New South Wales there. And that square acknowledgement that an intellectual disability is not a health problem, is not a mental illness, overall has had extremely positive benefits to people with intellectual disability. However, and I think this is very relevant to today, the tendency both from the disability community and from the health community was to move from that separation of services to a view that people with intellectual disability did not have mental health problems as did other members of the community. And that, I think, has been one of the main causes of the difficulties that people with intellectual disability now face in accessing mental health services when they do have mental health problems. Over the decades since the 1980s, the research evidence has grown, showing that that people with intellectual disability in fact have 2 to 3 times the rates of mental illness of the general population, and they have poor access to mental health treatment. That's not just me saying that. I mean, that is now squarely stated in the 5th National Mental Health Plan, that there is that high rate of mental illness and that great difficulty in accessing mental health services. And it's that research evidence plus the experience of our members that led CID to, from around 2000, to treating health issues, physical and mental health issues, where there's similar problems in both, but today we hear about mental health issues, obviously. That led to us making health a very large focus of our advocacy. And as has been valuable with a lot of our advocacy over time, we've found it really valuable to work with our medical and academic colleagues. And Julian's team here at the University of New South Wales is a key one of those. But there are, I won't list you, but there's lots of others in the room who we've found it really valuable to work with. So at a national level, there was a big step forward in 2013. Jane Halton, the then Secretary of the Commonwealth Department of Health, recognised the health disparities of people with intellectual disability, and 2 of the things that she did were to fund us to run the 2013 Roundtable in Canberra that a fair few of you attended, and that CID ran in collaboration with our professional colleagues. And that brought together people from the disability community, people from the professional and policy leadership in mental health and in other areas. That led to the 8 key elements that we will be talking about today. So arising from that round table, we came to a general consensus that there were these 8 key elements to an effective mental health response to people with intellectual disability. And I won't go through them in detail, but in essence, element number 1 is about inclusion of people with intellectual disability in all mental health initiatives and reforms. Number 2 is about prevention and early and timely intervention. Number 3 is about something that Michael and the Minister have both alluded to, the need for mental health services to have the skills and the aptitude to provide equitable access and fair treatment to people with intellectual disability. Number 4 recognises the fact that a lot of this is really hard, especially people who've got very limited verbal communication. Diagnosis and treatment and other mental health support is very challenging for mental health professionals. And so just like in so many other areas of medicine where you've got a population with complex and particular needs, you need some specialists to back up the mainstream. Number 5, collaboration. And again, we've heard about this. We've heard about this from a number of people today already, including Helen Christensen. It just doesn't work if we could have the best mental health system in the world for people with intellectual disability, but if it wasn't working in close collaboration with schools, with the NDIS and disability services, with the justice system and so on, you're not going to get any decent sort of holistic outcomes for people. The workforce obviously needs further development and needs to be well supported, and we need a lot more data. I mean, one of our challenges in getting the mental health needs of people with intellectual disability onto policy agendas has been the shortage of data historically to show in empirical terms the nature of the problems. But this is where the work that Julian has been and his team have been doing here at the university is providing more and more really valuable input, and Julian will be talking about some of the latest findings from his research a little bit later. Finally, multiple disadvantage. It's hard enough for a person who's got both an intellectual disability and a mental health need to get the supports that they require. But if you add into that, if someone's from an Indigenous background, if someone's got problems with the justice system, if someone's from a culturally diverse background, if someone's from the LGBTIQ community, you get sort of multiple disadvantage, multiple challenges for the service system in responding to the person's needs, and they need to be squarely met. So out of that round table came our challenge at the end of that round table was for people to go away to your spheres and look at what you can do in all your different spheres to move forward on better mental health care for people with intellectual disability. And we conducted an audit 2 years later, which we'd forewarned people of, and we found that there had been a lot of valuable incremental action in a lot of different spaces. The world hadn't changed by any stretch, and what Michael's told us today starkly emphasises that to us. But we had seen lots of useful incremental action. But not a big holistic response to a really important problem. the funding of the team here at University of New South Wales, the 3 pilot specialist intellectual disability health teams. There've been a range of valuable initiatives here in our state. But overall, what we still haven't achieved around Australia is getting the mental health needs of people with intellectual disability into the fabric of mainstream mental health thinking. All too often, we see valuable initiatives that just don't seem to have thought about people with intellectual disability. And that is very frustrating to us. And Michael really highlighted that frustration. On the positive side right now, and this we're hoping is a really important positive side, the final version of the 5th National Mental Health Plan squarely spells out those mental health disparities experienced by people with intellectual disability. And it squarely says that the activities in this plan and related activity by governments requires specific and appropriate application to groups with particular needs. And that's very much in the context of it talking about the particular needs of people with intellectual disability. And that to us is probably the core of what we are here about today, getting right into the fabric of mental health thinking, so that whenever there's a sort of new initiative, whether it's by a local mental health service or whether it's by at the national level, that people with intellectual disability are squarely considered. How do we make this work for people with intellectual disability, just as it needs to work for other sections of the community? I mean, much as we would like people with intellectual disability to, next year receive all of the mental health advances that are required for them to have a really high standard of mental health, I think the bottom line is that we are just about having a fair share of the action. I think today, the core of today for me, is about how we make the things that occur day to day in services, year by year, at planning level, how do we make them accessible to people with intellectual disability and responsive to their needs? I think that's what's called for by the National Mental Health Plan, requiring that specific and appropriate application of initiatives to disadvantaged groups, including people with intellectual disability. Thank you.